Let's talk briefly about vascular access in patients who are in cardiac arrest. Kyle, talk to us a little bit about different options we may have and also priorities for establishing vascular access.
So that's important to note. So let's first talk about priorities for establishing vascular access. So let's go back to, once again, our two major resuscitation pathways. Shockable rhythms, so that's VFib, VT, and non-shockable, which is PEA and asystole. PEA and asystole, vascular access is a high priority. The reason for that is you need to give epinephrine as your first-line therapy. Intratracheal epinephrine is not effective, and it's been removed. We should not be giving drugs down the endotracheal tube anymore. So you really do need to get vascular access fairly quickly in those patients. In the shockable rhythm, the VT, VFib, the first priority for that is defibrillation. So you put your resources towards defibrillation first, and then secondarily achieve access. Clearly, if you have lots of help, then you assign someone on vascular access. Now, patients may have intravenous access, but often patients on the floor with intravenous access, it may be fairly poor, and it may not actually be functional. You'd be surprised how often the peripherals are non-functional in a arrest circumstance. So you need to move for more definitive access. Early interosseous access is a must. You should not spend too long trying to achieve peripheral access. Definitely should not attempt central access before you've attempted interosseous.
Is this an option for people, intraosseous access? Where can they find these kits, and how can they learn how to perform this procedure?
So consult your own hospital. A lot of hospitals are now purchasing motorized interosseous guns that basically assist, because drilling through an adult bone is fairly challenging. It is something that's encouraged in the new guidelines, so get your hospital to purchase these, or figure out how best to get this in your own hospital. The tibia is where you usually do it, unless it's a total knee replacement. We actually have a little module on interosseous line placement, which we encourage you to watch. But once again, you need to kind of get over the idea that this is something just for pediatrics. This is moved into the adult population. But if you can't do interosseous access, you don't have it, you failed at peripheral access, one of your options is to do central access, and the preferred spot for that is the groins. The reason for that is that the neck and the subclavian, so the IJ and the subclavian, are not appropriate during compressions. You can't get access during. So the groin is the best spot. Now, Larry, let's talk about how challenging it may be to get peripheral access, or excuse me, central access in the groin. So when you feel what you think is a pulse during compressions, you don't actually know if that's the artery or the vein, because the pulsatile wave may actually be your venous buzz when you're doing compressions. So are there any things that our learners can do to improve their odds of successfully?
Well, I think a big thing these days is the use of ultrasound. Most hospitals now have portable ultrasound devices. There's multiple manufacturers that make these devices available specifically for aiding and guiding vascular access. And certainly they can be used during compressions to visualize the vasculature and to help guide central access. So I think, to wrap things up on vascular access, lots of different options. I think really part of your plan as a learner is to find out in your hospital where these resources are. Where is your intraosseous kit? Where is your portable ultrasound? Where are these resources? And familiarize yourself with how to use them.
Yeah. And one last statement on vascular access. I personally use the ultrasound in the groin, and I place both a femoral venous line and a femoral arterial line, both in the same procedure. I use a single lumen CVP for the arterial line, and I use a cordis for the venous line. You have a large resuscitation line, and you have an arterial line, both very useful in a resuscitation. But I do them all usually under ultrasound. It improves your odds, maintains a higher safety profile. It is the way that I think you should be encouraged to do it.
Great.
Great.